Hello, 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 hello. Hello, hello, hello.
Good morning, everyone. Welcome to TOS 2022. And today we will be starting the first session in Hall A, and that would be the live surgery session. I request the chairperson, Dr. Ravi Kumar Reddy, sir, to please come on the dais. And Dr. A. Ravindra, sir, the co-chairperson, Dr. Ashish Bansal, sir, Dr. K.B. Nankishore, sir, Dr. Manoj Mathur, sir, as the chair people, and Dr. Somshila Murthy, ma'am, if she's around here yet. And we'll be waiting for Dr. Rishi Swarup, sir. Dr. Aishwarya Rao, you're here? All right. So if we have the permission of the chair people, can we start the session, sir? Right. We'll wait for a few minutes if you require. We're just waiting for 5 minutes for everyone to come over, and we can quickly begin the session right on time.
చందు జూమ్ వస్తుంది కదా ఒకసారి మాట్లాడు నార్మల్ ఒక 5 minutes చాలు అంతే
వస్తా ఉంది లైక్ అంటే చెక్ చేస్తా ఉన్నాము రిగార్డింగ్
రైట్
వీడియో
వాయిస్ క్లియర్ వస్తుందా
హలో
క్లియర్
రైట్ డన్
మదన్
లైక్ మా లైవ్ వచ్చిందా?
Okay, so we have the permission to start the session now. So our first speaker is Dr. Aishwarya Rao, who will be talking on a brief look at ophthalmic anesthesia. So I request Dr. Aishwarya to please come over.
Good morning, everyone. My name is Dr. Aishwarya. I'm a first-year PG at Pratima, and I'm going to be talking a little bit about ophthalmic anesthesia, specifically in relation to cataract surgery. First, I'd like to start by thanking everyone at TOS, the scientific committee chairman, as well as my mentors, Dr. Badrinarayana, Dr. Jagan Mohan, Dr. Parmeshwar Rao, and Dr. Ravindra for giving me this opportunity and encouraging me to speak here today. Now, all local anesthetics have a similar structure. They are tertiary amine linked with an amide or ester bond to a aromatic residue. So they have a hydrophilic end and a hydrophobic end. They're often given in the form of hydrochloride salts. This is because they're far more soluble in this form and will undergo a slower hydrolysis, allowing for a longer duration of action. Block is achieved faster in unmyelinated fibers than in myelinated fibers, so pupil dilation occurs first, followed by analgesia, anesthesia, and finally akinesia. Local anesthetics can be broadly divided into regional and topical or intracameral. Among regional drugs, bupivacaine has a longer duration of action, up to 4 hours with the addition of epinephrine. Here, I want to make a distinction between amide and ester drugs. Amide drugs, which I've highlighted in green, are generally preferred because they have a longer duration of action and are much safer because they have less systemic side effects. Epinephrine, sodium bicarbonate, and hyaluronidase are often added as adjunctives to local anesthetics. With epinephrine, the maximum dose is 2.4 micrograms per milliliter. Beyond this, we have a risk of decreasing the vascular supply of the optic nerve, which could cause ischemia. Now, with hyaluronidase, it's added to increase the tissue dispersion of the drug. The maximum safe dose is 500 international units per milliliter. Higher doses have a risk of hypersensitivity reactions, especially in patients who have a known allergy to insect bites, because the insect bite saliva and the animal-derived hyaluronidase have similar biochemistry. Anesthetic delivery techniques in cataract surgery. So with the retrobulbar block, the injection is given into the muscle cone. So it produces a block of the 5th, 6th, and 3rd cranial nerve. So all the secretions and all the extraocular muscles, except for the superior oblique, are blocked. It's not used commonly today because it doesn't produce any kind of facial anesthesia, and additional facial block has to be given, usually a modified Van Lint. And the rate of complications is quite high with this block, like retrobulbar hemorrhage, which is pictured here. Globe penetration and optic nerve injury can also occur. Optic nerve injury could lead to brainstem anesthesia, which is a rare but dire consequence. The symptomology ranges anywhere from bradycardia and confusion to coma, apnea, and cardiovascular instability. So we have to look out for that. Facial blocks, these are the various facial blocks, but we tend to not prefer them because they're painful, they cause skin bruising and more serious complications like palsy. Peribulbar blocks are preferred over retrobulbar because they're injected outside of the muscle cone, producing less complications. They spread easily to the lid and other orbital spaces, so we don't have to give any additional facial block. In the procedure, it's important that the patient be lying supine with their eyes fixed in the primary gaze. This is especially important because if, for example, the patient is looking upwards and medially, then the optic nerve comes into the direct path of the needle. The bevel should always be facing the globe when inserting the needle. The needle should be inserted parallel to the orbit floor. So in the inferior injection, bevel will be facing upwards, and in the superior injection, it'll be facing downwards. Aspiration before injection is an important mantra, not just for this, but for all needle blocks. Slow injection of local anesthetic and ocular compression help to mitigate the IOP rise. It's contraindicated in people with high myopic eyes, posterior staphyloma, and enophthalmos. Disadvantages of peribulbar block, the main thing is that it's a more painful procedure and produces less complete akinesia, so multiple injections might be needed, at which point it's really no different than a retrobulbar in terms of complication rate. This is where Sub-Tenon injections come in. It's considered an episcleral injection. It avoids using sharp needles in the orbit, so there are less complications. The anesthetic agent is given in between the sclera and the Tenon's capsule. The only disadvantage is that it's quite difficult to perform, especially for someone that is new to the block, especially in patients who have a previous history of ocular surgery. This is the Sub-Tenon injection procedure. The patient is asked to look upwards and lateral, and we lift the conjunctiva and Tenon capsule at the inferonasal quadrant. Then using a closed Westcott scissors, we first give a cut, and then closed Westcott scissors are used to create a thin channel in between the sclera and the Tenon capsule. After which we use a blunt curved intraocular cannula like a Stevens cannula, introduce it into the space, and with the rotation of the syringe, we will give slow injection of the local anesthetic. This helps to mitigate chemosis and also helps in better spread of the agent. Do's and don'ts in Sub-Tenon injection. We should keep the cannula tip in contact with the sclera to avoid overshooting or perforation. We should not dissect past the equator. So how do we know we've reached the equator in the first place? When advancing the Westcott scissors, we'll feel a sudden loss of resistance, indicating that the equator has been passed. We should not give ocular massage. Instead, a gentle digital compression is enough. So topical anesthesia is increasingly being used, especially in phaco surgeries. Here, the agent is applied directly to the surgical site. So all the complications we've talked about so far are needle related and are not a concern in topical anesthesia. It's given either as eye drops, a gel, or a sponge soaked with local anesthetic, as pictured here. This is useful because it prevents rapid clearing away of the agent. The main advantage the topical anesthesia provides is that there's almost immediate visual recovery. However, if given alone, the patient perceives more intraoperative pain. This is because there's no akinesia of the eye. The patient is always awake and often apprehensive. And topical anesthesia really only blocks the free nerve endings of the trigeminal nerve on the conjunctiva and cornea. So it's often combined with intracameral anesthesia, where the agent is irrigated into the anterior chamber. This helps in decreasing ciliary nerve irritation and for better instrumentation. The only disadvantage is that it could cause endothelial toxicity and intraocular inflammation. Intracameral anesthetic agents must be preservative-free, otherwise they would damage the corneal endothelium. It must be given prior to the injection of visco because the viscoelastic tends to coat the surfaces and prevent absorption. It can also be used adjunctively during the hydrodissection step. Newer agents are commercially available as a combination of tropicamide, phenylephrine, and lidocaine, so it produces sustained mydriasis as well as anesthesia. It's relatively contraindicated in patients who, for example, have small pupils or vitrectomy might be needed in them. When do we use general anesthesia? Well, in pediatric age group patients, in mentally unstable patients, or patients who have diseases like Parkinson's, we tend to use mild sedation with either midazolam or fentanyl. So how do we know which anesthetic agent to give in which patients? Well, there's no blanket formula that we can apply to all cases that we would encounter. Instead, the decision must be made taking into consideration the resources available, our skill as a surgeon, and of course, patient comfort. Here, topical anesthesia with ICA stands out among the other options, and it's increasingly being preferred, especially for phaco, but it's not suitable for all patients. We have to first ask ourselves, can the patient lie flat for the duration of the surgery? Will they be cooperative and look into the light, or are they prone to being anxious and claustrophobic? Regardless of how well we screen patients or how expertly we give a block, a clear line of communication between patient and surgeon, thorough counseling, and reassurance will go a long way in ensuring patient satisfaction. Thank you. Okay.
Dr. Rishi, Dr. Shomshila, please. The excellent talk by the young ophthalmologist, as though she has done so many cases. She has presented all our practical tips. All she has given practical tips. Only thing is, when it is short duration of the surgery, we prefer topical. When we have a long and expecting some complications, definitely we prefer our blocks, either in the form of Peribulbar or Sub-Tenon. Any of you have any questions?
I need to add one more point. I'm Dr. Sharath. I just want to add one more point that you should not add adrenaline in the Sub-Tenon's injection.
Right. Sir.
No,
So that
in that matter, any combination, don't add adrenaline, because majority of our patients are geriatric. You cannot add adrenaline for any of these anesthetics. Only in very young people, other than cataract surgery, where you do oculoplasty, where the duration you expect more. Say, for example, dichrosis or rhinostomy, especially in young patients, there you can add. But cataract surgery, there is no role of adrenaline.
If there are no questions, I'll hand it over to our audience.
Thank you, Aishwarya. That was a wonderful session. I now request Dr. C. Sharad Babu, sir, to please come for his talk on Clarin aspheric IOL and autonomic system. Over to you, sir.
No, this is not the one. Clarion. This is the Optiflex Trio IOL, which I'm going to implant in the live surgery. This is at 12:15. That is again a promising IOL, which has been introduced in India. Getting more popular. Clarion. So the Clarion is one of the monofocal lenses introduced by Alcon. And Alcon today, they are sponsoring live surgery. So they have the Alcon, the Biotech, the Zeiss, and I think three or one more company. They are doing the live surgery. And so in between, we are going to have these small lectures introducing what is the latest in ophthalmology. So this Clarion, this is what I want to tell you about. This is a newly introduced monofocal IOL from Alcon with a separate delivery system that is called the autonomy. That is, you press it, it just pushes the IOL outside. It's a mechanical with the carbon dioxide cylinder, which pushes, that is the one. It is a preloaded IOL. So what is the difference between this IOL and the earlier IOLs? So overall, you have to see what is the bioptics, biomechanics, the material, what it is being used in this type of, in this Clarion IOL. So I was surprised, I was sharing this in one of the other meetings in Hyderabad. Clarion, I was just finding out how many IOLs have been implanted. It's been introduced almost a year back, or year and a half year back. So I asked the Alcon people, they said around 800 IOLs I have implanted. So I went back and then again searched, I found I almost implanted more than 1850 IOLs. This is a very, very good IOL because of the biomaterial. I'll tell you what exactly it consists of. The material is completely different from the previous IQ IOL. It's a methacrylate polymer. So the advantages of methacrylate polymer, I'll explain you. And then of course it's a blue light blocking IOL. And the size and everything is the same. The optic size is 6 mm, but the shape is a little bit different. It's a precision edge IOL. Is a difference between the edge, that is the steep edge is a little bit truncated. It has got a little bit advantage over the other IOLs. The IOL after implantation in the eye, it is very stable. Once you implant it, it stays horizontal. What happens after they put the IOL after a while, the capsule contracts. Even it constricts up to 9 mm, still the IOL is very stable. It stays horizontal. So the effective lens position of the IOL remains the same in this IOL. The edge, this is what I am talking about. This has got a truncated edge posteriorly. It has got two advantages. One is preventing the glare. The other one is preventing the posterior capsule opacification. So these are the different comparisons of this IOL with other IOLs. So the edge curvature is a bit different so that this prevents the glare, edge glare post-operatively, and patient feels more happy. We see a lot of patients coming back post-operatively and complaining of dysphotopsia, negative dysphotopsia, and some of them entoptic phenomena, and some of them about this glare. This glare is about this edge and also the capsular excess edge. These two things, one part is the IOL truncated edge is taken care of. The other things are the subsurface nanogranules or the subsurface glistenings, nanoglistenings. Usually when you see an IOL, after a while after the implantation, you see this glistenings in the IOL. That is because of the cut, how it is been done. So if it is done a lathe cut, usually these things are not seen. But in other IOLs, you see a lot of these glistenings. But in Clarion, you don't see that because of the material, because of the HEMA, that is a hydroxyethyl methacrylate material of this IOL. The surface haze, this is what I am talking. when you see any IOL, one is the glistenings, the other one is the subsurface haze, which is not seen in this IOL. This has been introduced 1.5 years back, but also introduced elsewhere very long time back. So you never see these glistenings in this IOL. And the patient's comfort is the ultimate, like post-operatively. The size of the optics is the same. The haptic, the overall length is the same. The thickness also is the same. The difference between the earlier and this IOL is the anterior surface of the IOL is aspheric, whereas in the Aqueous of IQ design is the posterior surface. The Clarion is coming again in the panoptics and also with the toric IOLs in the future, probably 2 or 3 months after. And it's got a blue light filter that is 400 nanometers. Most of the blue light is filtered. And finally, talking about this, the material, how it remains in the eye. It is the perfect IOL in the eye, and it's very easy to implant. That is because of the autonomous system. I'll just show you how it is. The IOL is pushed into the bag at a speed of 3 millimeter per second. So it slowly goes inside. You have a control. Yeah, it's not coming. Probably you can see in the live surgery. So this is how you hold it, and then press the button, and then the IOL is pushed inside the eye. So coming back again, the future of the monofocal IOLs, when you think about it, the preferable IOL is a Clarion monofocal IOL. Thank you very much. And 12:30, you have a live surgery on Optiflex, and that is being relayed here. I am going to operate. Thank you. Any questions on Clarion? Thank you very much.
Thank you so much, Babu sir. Next, we have the live surgery session by EYECON by Dr. Rupak Reddy. Could we have the connection with the live surgery session, please? The AVT. Just give us some time to connect with them. They're already ready, so we'll just put them on.
Any questions on Clarion? One advantage is preloaded. The other, what they claim is the material is different from that of IQ. So when I implanted this IQ lenses 15 years ago, these lenses, definitely there is some amount of glistenings.
Chandu,
So
మీ
where
feed
patient
live,
may not complain.
right.
Is it ready?
Right,
Yes, sir,
audio,
they're
audio,
ready.
audio, sorry,
Just coordinating with them for 1 minute.
audio.
I request delegates to come to the center so that they can watch live more clearly, because delegates sitting in the corner, they may not see clearly.
Dr. Rupak Reddy, sir, can you hear us? Bashir ji,
Chandu, audio.
can you please set up?
Audio is clear. Audio is clear.
Okay.
We are just setting the column mic to surgeon.
Okay.
Sir, you can speak, sir, so that they can also hear.
Good morning, Rupak sir. All of us are here ready to see your surgery, sir.
Sir is talking. Is it audible?
No, he is not audible. Could you please
Oh.
connect or try to connect again?
ఏదో ఆన్ ఒకసారి ఆన్
So
లేదా
could you
మైక్
provide the details of the case really quick? You have it? Or- So we're not able to hear you yet, sir. Sometimes the collar mic works only if you put it on the mask.
నో నో వస్తుంది చందు వస్తుంది ఆ మాస్క్ వల్ల కొంచెం
Maybe
ఆగిపోయింది
somebody
ఒకసారి
from the
ట్యాప్
center
చేయి
can
దానిపైన
tell us
ట్యాప్
about
చేయి
the
ఉంటే
details of the case.
మైక్ మీద ట్యాప్ చేయి
Hello, am I audible?
Yes,
యా
yes,
యా
Yes, sir, you are audible, it seems.
Am I audible?
yes. Dr. Rupak Reddy, sir, the audience would like to know a little about your case. So if you could familiarize us with the case that you will be looking for.
Yeah, I'm waiting for the case to come, madam.
Please, sir.
Hello. Can you reduce the volume in the OT, please? Am I audible at the audience, please?
Yes, sir.
You are audible.
Yeah, thank you so much. So this is a 60-year-old male patient with his old glass minus 3.75, visual acuity at 618. Best corrected is with visual acuity with -4 sphere is around 612. This is a grade 2, both eyes immature cortical cataract. Any other information required?
Okay, any astigmatism?
No astigmatism, so no notable astigmatism.
Okay, okay.
43.32 and 42.6. I'm just waiting for the OT table to be ready. In between, if you have any other doubts or any queries, I'm ready to take.
What is the phaco mission you are using? What is the?
We are using a Centurion vision system. If you can zoom in on the parameters, it will be helpful. Or the parameters are on the live relay. Parameters on the live relay. You can zoom in on the machine.
Yeah.
Show the parameters, please.
Rupak, what is IOL you have planned?
Sorry, sir.
What is the IOL you have planned?
IOL is a Clarion IOL, sir. 22 powered IOL, Clarion IOL. Volume. The audio from the live relay is not clear to me. I am not able to hear from your end, sir.
చందు
వేణుని ఆ సౌండ్ పెంచుకోండి. ఆ సౌండ్ పెంచు. ప్రెషర్ చూసినా డ్రేప్ చేయండి. Point 8.
మీకు అక్కడ ఏమైతే ఉందో చూడాలంటే చూడండి.
Okay, Ram.
In the meantime, can you tell us that how have you arrived at the IOL power? What formula did you use to calculate the IOL power? Are you able to hear us?
Yes, sir.
Could you just comment on the what formula you have used to calculate IOL power?
IOL formula, which IOL formula you are relying?
Yeah, we have calculated with SRKTA.
What about the Barrett's universal?
We have already cross-checked with Barrett's with the similar IOL power, sir.
You use Barrett's T or Barrett's?
Universal 2.
You're planning to use topical anesthesia?
They were blocked, sir. Depend. Patient is a little apprehensive, so given a mild block with small movements. Yeah, increase the light and increase magnification, please. Up more. Magnification increase, please. Increase magnification, please. You are decreasing. I'll do it. That's fine. It's fine.
Hello, what is the microscope being used?
We are using a Zeiss Lumira eye microscope, sir, with Callisto. Sir, I am waiting for the OT staff to get ready. Ring. Long Jesus. Comfortable on the sir? Comfortable on our? Okay. Main.
Could you tell us, have you used any antibiotic prophylaxis pre-op? Any antibiotic drops or betadine drops, or what do you use?
Before, sir, or after?
Before.
Before, patient is on prophylactic antibiotics 4 times a day, 1 day before.
And that is a moxifloxacin or?
Moxifloxacin.
Do you use betadine also? Before
Betadine, yeah, before preparation. Just before surgery, sir. Patient is prepared with betadine. Shall we proceed?
Please proceed.
Wash. Dye. Wash. Visco. Side port. Rexis marker.
Do you use capsular staining in all patients?
Majority of my patients are, but most of my cases are femtosecond based surgery. So I don't use any capsular staining in my femto cases, but other cases I do use capsular staining.
For demonstration case. Better, no?
Visco. Visco, regular visco, normal visco.
What visco you are using?
This is viscoat, sir. Viscoat.
That's what you will use in all patients? In routine, that's the one you use?
60 tome, please.
I was asking that, do you use viscoat for all types of patients or?
Yes, sir. I do use viscoat to coat the endothelium for all the cases. Wash, please. Awesome.
Is your axis always clockwise or sometimes anti-clock?
So it depends, sir. Majority of the time I do anti-clockwise. I'm right-handed surgeon, but still I do anti-clockwise.
Specific in certain
Wash.
cases, certain cases like this. Any predilection for any?
2cc cannulas, Vishnu. Visco. Dialer. Chopper. Echo. Fico.
Slight decentration. Somebody can, fine.
Centration is okay.
Yeah, fine. Can somebody tell the parameters?
Continuous chop. No pulse. Continuous, please. No IP. Continuous, no IP. No. Increase vacuum. Power, please. Power. 70. Wash, please.
Why do you prefer continuous mode over pulse mode?
It is smooth delivery, sir. It is very minimal power.
Okay.
I don't want any chatter of the nucleus outside. So this is a nozzle one. So I use continuous nozzle. No need for any bus or nuclear modifications. Sir.
It seems CDC is 7.
7.
Yeah.
Pretty great. 2 to 3 around. I use less than 5 to 7 CD continuous dissipated energy.
Yeah.
I'm doing a bimanual cortical aspiration.
That was a pretty quick and clean.
Yes.
grouping.
It seems you have almost done in the bag. Everything in the bag, no? Notice that the moment of the aspiration is the tangential, so that there is no traction on the zonule. Is always moving his aspiration circumferentially. Small block of the posterior block is polishing.
No.
Small fibers you can do like that.
The advantage of pulling it circumferentially is that you are putting less pressure on the zonule.
Yeah.
And also you can aspirate a bigger chunk in one go.
Yeah. So that no tears in the capsular cortical.
Right.
Now he is
Now
ready,
shift towards the IOL, please.
is ready to inject that clarion.
Preloaded clarion. You can see the IOL power.
Just up.
There's a small port inside for viscoelastic. I'm pushing the viscoelastic viscoat throughout. Let it come throughout.
But not visible.
Just shows the injected through the microscope. Yeah.
Microscope. Through the microscope.
Is it okay?
1 minute. Show the probe port.
Viscoat. So this is the port. We inject the viscoelastic through the port. Push the viscoelastic all throughout till it comes out. There's a guard here. We remove the guard. We discard the guard. There's a click mechanism on the cartridge system or the injection system. You're able to see.
Yes, yes.
We will press the click and wait till the IOL advances. We wait slowly till the IOL advances to the edge. Okay.
Yes.
Now within 1 minute, we are supposed to inject into the eye. Wash, please.
Focus, focus.
Is okay? Is in the center. Dialer, please.
Fine, fine.
Dialer, please. This is chopper. Dialer, please.
Dialer with the left hand.
Dialer, please. Wash. So you are giving me chopper. Please give me dialer. Wash, please.
What wound size this injector need, the tip needs?
This I've used a standard 2.8 incision. Sir, this lens will go in 2.2 also. So directly injected onto the bag. Just gently dial the lens or nudge the lens into the bag. And that's about it. And then we'll proceed to wash. Wash.
Nice demonstration. Any doubts about this surgery?
Wash, please.
The irrigation under the IOL now.
Increase bottle height, please.
What is the IOP now?
IOP is around 60. We have increased to 65. Now decrease the IOP to 30, please. Decrease the IOP to 30. IOP is now 30. At 30 also the machine is able to maintain the chamber. Decrease to 20.
20. Okay.
20 also the chamber is able to maintain. This is around 50 IOP. Small cannula, sister, small cannula.
Do you hydrate all the wounds routinely or you look for
Yes,
any?
I hydrate routinely all the wounds, sir, all the wounds. Some more fluid, please.
Subconjunctival injections after finishing surgery?
Sorry, sir.
Subconjunctival injections after finishing surgery?
No, I usually give intracameral moxifloxacin, sir.
The cameral maxi you use.
The intracameral moxifloxacin.
Post-operatively, at what time you give glasses?
Sorry, sir, what time?
Last prescription after how many days?
2 to 3 weeks.
Prescription after 3 weeks, sir.
3 weeks.
3 weeks.
So anyway, it's well performed surgery. Congratulations, Rupert.
ఆపరేషన్ మంచిగా అయిపోయిందండి. మెల్ల కళ్ళు మూసేసాం. మూసేసాం.
Anything you want to tell Dr. Rupa?
So in the last step, I have decreased the IOP up to 30.
Take double the time.
Patch.
Hello.
Yes, sir.
In this setup, you have taken double the time, but you did a
Yeah.
good job.
Yeah. So it
Anything
was,
you want to tell
team
about
was not
that?
ready, so I had to take some more time.
Yeah. Anything you want to tell us?
No, in the last step, I have used around 20 to 22 IOP. So with this machine, we can go definitely up to 20 IOP.
Okay.
So because there is a sensor, active fluidic sensor in the handpiece, the pressures we can monitor for different kinds of situations. This is a regular routine case, but in a difficult case like in a myope, or if you want to have more IOP in a hyperope, this all can be adjusted with the machine, and the handpiece is having a sensor which is very much responsive. So it will automatically adjust your required IOP onto it, and there is no need to enter any patient eye level. So you don't have to concentrate on the bottle or bottle height. So the patient eye level is automatically monitored with the sensor which is there in the handpiece. So that also adds to the stability of the eye. So throughout the chamber, throughout the procedure, you might have seen rock solid chamber stability.
Yeah,
We never had any chamber loss or anti-chamber collapsing or any other thing. We were working with less and less bottle height. Throughout the procedure, we were working around 50, 55 IOP. That translates to 70, 75 bottle height. Usually with traditional phaco, we do around 85, 95, 100, maybe probably some surgeons do at 110 bottle height. That is routinely not required. So this translates to lesser and lesser fluid into the eye and lesser turbulence inside the eye. So as the turbulence goes, the endothelial count or the safety towards the endothelium adds up more. So our reliance on high-end viscoelastics goes down. Though I've used viscoat in all my cases, but I feel that in 1 or 2 cases where I don't use viscoat or endothelial protector also, majority of the corneas are crystal clear. So I feel that apart from the energy delivered by the phaco machine, you also have to consider the fluidics, which cause a lot of turbulence inside the eye. So these turbulences also are taken care with the machine. As high-end machines, and these have lots of sensors, the amount of fluid passing into the eye or the speed at which the fluid is going through the eye is lower and lower. So this translates to lesser and lesser damage to the endothelium. So we have got lots of modifications in the phacoemulsification procedure and the energy modulations. But I feel that surgeons are little lesser, we are more lesser concentration on the turbulence of fluid inside the eye. So with the active fluidics of the machine and with the reduced IOP, we can control the turbulence so far, at least in majority of our cases.
That means one is coating the endothelium with viscoat.
Yes, sir.
Fluidics, and doing the phaco in the bag will prevent the damage to the endothelium.
Yes.
And try to use as less fluid as possible into the anterior chamber.
Yes. We can use more fluid, but with less turbulence. Less turbulence.
Yes, less turbulence. So more than the phaco energy, you believe that turbulence also important for endothelium.
Primary is phaco energy, secondary is turbulence. But when we want very good refractive results after cataract surgery, we have to consider everything. So the small things like turbulence also do matter more. This is my belief.
Okay.
Hello?
Yes.
In the back or in the pupillary plane.
Clarion and Aqueous of IOL, in my experience, almost visual recovery is almost same. Very similar.
Clarion, any other lens, huh?
We have been using the lens around 7 to 8 months. No significant PCO rates difference between the IQ platform or the Clarion platform.
They claim that the material of Clarion is far better than that of IQ. They claim. The other thing I noticed is the junction between the optic and the haptic lever that is more flexible in Clarion when compared to IQ.
That's correct. So the lens is more and definitely more maneuverable inside the eye, both while injecting and while manipulating the lens inside the eye.
Okay.
That's all. Thanks.
Thank you.
Yeah.
The next thing.
Thank you, Rupak sir. for your live demonstration. I would like to request the chairpersons to allow the lecture on Panoptics Trifocal IOL by Dr. Srilakshmi Nimagadda. I welcome her onto the dais.
Hello.
We'll have a live surgery.
Can you
by
hear me all?
Advait Alampur.
Hello.
Thank you. Very good morning, one and all. At the outset, I would like to thank TOS and Dr. Santosh Honavar for the opportunity. Sir, very good to see, very proud to see Dr. Rupa Gandhi and IS doing next generation, doing wonderful things. Extremely happy, sir. Play. So I was asked to speak on Panoptics, which is a trifocal IOL from EYECON. So let us see, like all these days, the manufacturers made us believe. Some loose connection, okay. Made us believe that by providing bifocal as a multifocal, then the trifocal thing came and they said, no, that is not multifocal. This is the true multifocal. So the reason for this trifocal in the our practice is most of us now, most of the population now onto the intermediate distance tasks like laptops or even iPads. And old women sitting at home also now trying to use the laptop. So it's gaining importance over the years. So I'm skipping all these slides. So it has a peculiar quality, that is enlighten or enhanced light energy optical technology. I'm going to discuss on that. So how it is different from the EYECON's Restore is Restore has it has 9 steps, but it is known as apodization technology, where the apodization primarily used to use the light energy even in a mesopic conditions. But here, the Panoptics without non-apodization, having a good central zone, has covered up that with the enlightened technology. So this is the first step. Bifocal is 1 step height and 1 add power, but it is not providing the intermediate vision. So they have come out with low add powers to give us that blended vision. Remember, Restore has plus 2.5 add, which can be implanted in the dominant eye, and plus 3 add for the non-dominant eye, so that you can have all ranges of vision known as a blended vision. Instead, the trifocals give us the 2 step heights where 2 add powers are there. That is in the regular traditional trifocals. So how it is Panoptic is different, well, let us discuss now. So in a
first lens,
due to diffractive nature of the optics in traditional trifocals, you can see that the focal points, the distance focal point at the, imagine at the infinity, the near point, the first intermediate point is double of the near zone. That means if near zone is at 40 centimeters, the intermediate zone is at 80 centimeters that you see in the traditional trifocals. But how Panoptic works is, it is primarily having 3 step heights, 3 add powers. That means
We'll be starting shortly. Okay. Just close your eyes.
Primarily, it's a quadrifocal technology. See, there is an extended intermediate zone in this IOL. So the near zone, 40 centimeters. The first intermediate is at the 60 centimeters. That means 1.5 times of the near zone. And the extended intermediate zone is located at the 120 centimeters. So there is an optical manipulation with that. This extended intermediate zone light is diverted to the far distance vision. So that is known as the enlightened technology. Just the slide. I'm skipping it over. There are so many slides like this. So this is the redistribution of light energy to the distance, so that in all light conditions, it can work better, even at a distance of 60 centimeters. So we are not, Indian population is not as tall as Europeans are, Western world, where 80 centimeters is maybe good for them. But for us, 60 centimeter works very well. That's how panoptics has become very popular all over. These are the same slides showing how enlightened technology, how the primarily it's a quadrifocal technology having 3-step heights and the redistribution of the light from the extended intermediate zone to the distance, so that the light energy will be 80% to the far and 25 each for the intermediate and near is distributed. So this is what it's showing, that transmits 88% of light at 3 mm, and also it is pupil independent. Any kind of allocates half of light to distance, splits the rest evenly between near and intermediate. And there is a comparison of the other trifocals like Zeiss and Visual, where the superiority of panoptics has been shown. Same kind of slide. It is superior panoptics even at the far here. 60 centimeters, how it works.
First phenylephrine. Okay.
The same thing it's talking about. So there is a comparative slide between Dastor and panoptics. For panoptics, it is not dipping at all levels. It is its performance is superior because, and obviously bifocal, it is a bifocal. Dastor is a bifocal, so it lacks that intermediate vision. And then comes to the diffractive zone. This diffractive
It's close
is 4.5 mm, unlike the other trifocals. So this is important because if it is smaller, it compromises near and intermediate performance in low light or in large pupils. Any of our pupils are smaller, and if the zone is larger, it compromises distance vision in mesopic conditions. This slide is particularly showing like IQ platform only is the one which is based on panoptics is based on the IQ platform, which been over the years it's proved that it's highly biocompatible. This particular so many other features been showing, but that very correct on panoptics is 0.1. Compared to the other including restore or and fine vision.
Aspiration
as good as this is bifocal defocus curve showing its performance. So defocus curve is always used in any multifocal to show its performance in all ranges of vision. So subjects who received the panoptics IOL, it's a study where panoptics IOL achieved a mean visual acuity of 20/25 or better from +0.5 to -0.5. That is the default showing. And then there is another study by Garcia and Perez where a very brief study of 1 month, but it was all initial studies. Those slides were given at, I think, in 2018, but now they proudly claim that panoptics implantations across the globe, 1 million, including
Actually,
also himself had this IOL implant.
I put Visco.
Thank you. That's all about panoptics. Small view.
Yes, we have the same microscope, so that's why it's good.
Just to show this. So panoptics also has a toric version. So you know that all the multifocals and EDOF lenses are very, very sensitive to do even a low grade astigmatism. So any small astigmatism better to go for a toric, especially multifocal scenario. So just want to share small video, that's all. Thank you.
Any questions? Nice presentation. One is, what is the limit of your cylinder in choosing the panoptics?
Any multifocal, sir, primarily if it is 0.75 and above, you should never treat the spherical power. You have to treat the astigmatism because that.
Beyond 0.7.
Yes.
What is the upper limit?
Upper limit, what is the range? Whatever range they give. Sometimes the patients are so, they ask about these glasses free, then you can probably implant this and check whether they can have some laser correction or some kind of, arcuate incisions,
So one prerequisite for all these panoptic lenses is a good topography or even pentacam.
Yeah,
So,
biometry, yes.
After pentacam only you promise them. Before that, don't promise, because the irregular surface of the cornea, whatever best surgery you do, you cannot convince them. So once the pentacam or the topography is perfect, then especially the bow tie pattern, they are the happiest patients. Wherever there is irregularity in the surface, they are unhappy patients. We spend so much of money. We are not. The other thing is a patient with white cataract. I call them as corona cataract. So a corona cataract patient, do you promise panoptics? You promise?
You're asking me, sir? Yeah. Probably, because now we have sweat source by optical biometers. If you have that kind of, biometry with you, I think I'll still do it, sir, because as you said, I do all the scans, including OCT, if not white cataract, oculizer, everything. And I counsel my patients in case, if they're in spite of, doing all these scans, if there any small residual error remaining, wait for a couple of months, 3-4 months, then let me do a laser touch-up absolutely free.
Yeah, that is one thing. Another thing is, as you know, majority our patients are associated with diabetes, hypertension. The third is heart. These type of patients come, they only insist on the panoptic. We don't want glasses. We don't want glasses. So there, be aware of the retinal problems, especially EYECON. We come across 1 or 2 promises. Ultimately, the result are not happy. Why? Means there is EYECON. EYECON is not picked up by any means in a white cataract, corona cataract.
Even in a grade 3 to 4 nuclear sclerotic cases, still we can see the fundus details, but this particular AON will not appear like that pale disc. And after the cataract removal only will know.
Is okay. I totally agree. We have a batch of retinal surgeons. They concluded, when there is no view, be cautious about promising panel. When there is no fundus view.
But what you said is right, sir. AON will definitely be missed out. Even in, if not white cataract, it's advanced.
Majority are associated with hypertension and diabetes.
Yeah, and then even if it is not panoptics, even monofocal, you will have a lot of music from the patient later.
You are right. But the more music is in panoptics because they paid more. Any questions? For all the people practicing panoptics? Somebody? It's a very good lens, provided you thoroughly, preoperatively, you can satisfy. We have implanted on the doctors, we have implanted on IAS fellows, we have implanted on engineers. But before that, be confident yourself. I can give him a good vision. Then promise them. If you are in doubt, don't promise. In doubt means when you are not able to visualize the fundus. That you give one word. If your fundus, if your retina is okay, I can give the best vision. That point you underline it. The other day, one 84-year retired IAS came. Do you promise? Means I don't promise because you are having hypermature cataract. Yes.
So, thank you so much, ma'am. Our next session is with Dr. Advait Sai Alampur, sir, and he's ready in the OT and the live surgery with biotech. I request their team to please go ahead and choose their case. Can you hear us, sir?
Patient.
Your voice is clear, sir.
Hello. Hello.
Yes.
Let me now introduce our next second guest surgeon, Dr. Advait Sai, who is going to perform a phakic IOL surgery.
Good morning, everyone. I'm Dr. Advait here. Am I audible?
Yes, sir, you're audible.
Yeah, thank you. So we have a 21-year-old female. She's a biotech student, and her diffraction is -8 with the -0.75 in one eye, and that's the eye that we are going to do the acryl phakic IOL. So she's not eligible for the LASIK surgery, so we've deferred the LASIK surgery. Her PACI is 502 micrometers, so the thickness is not sufficient to go ahead with the LASIK surgery. So we are planning the phakic acryl IOL.
Person.
So the anterior chamber depth is 3.2. Our refraction is -8 and -0.75, 180. We've taken the spherical equivalent, so we're going for a non-toric phakic IOL. And we are doing it under topical anesthesia and temporal. So I'd like to load the lens first. Keep your eyes closed. Visco. So the loading of the lens is just like a regular cataract intraocular lenses. It's a hydrophilic lens. If you can see, the orientation mark is on the left leading and the trailing right. Is it clear, the audience there? Can you see the orientation mark? Yeah. So this is how we check if the lens is placed correctly. And then we place it into the cartridge. Just need to make sure that the lenses are moving smoothly. If it is moving smoothly, then it is present in the group. So I'm just going to leave the lens here and go ahead with the surgery. Smoothly, just open your eyes now. Just look down. Just look straight into the light. I'll reduce the brightness of your spooting. Just look straight, please. Look straight. Yeah. I put in 7. Spooty, look straight, please. Don't move. Open both your eyes, Spooty. It'll be easy for you. Open both your eyes. Look straight now. Lift your chin, please. Yeah. Look straight. Don't move. Side port. Hoskins, side port. Hoskins. I normally take 2 side ports because I use a bimanual irrigation aspiration. Don't move, no? Look straight, Spurti. Using a Phenocan now. Sorry. Let's go. Let's go. Look straight, Spurti. Look straight, please. Don't move. But this content 2.2. Look straight, ma. Look straight, please. Open both your eyes. It'll be easy for you. Hoskins 2.8. Look straight, ma. Look straight, please. Look straight. Spurti, can you look straight, please? There's a focus there. Okay. No. Yeah. Instrument. So the advantage of these lenses is it goes in well with the 2.8. I've just slightly extended the inner lip. Saline cornea. Look at the light, man. Don't move, please. Look at saline. Look straight, don't move. Let's go. So this step is very look straight, Spurti. Can you look straight, please? Look straight. Look straight. No, look straight. Can you open both your eyes and look straight? Spurti, can you look straight? Open both your eyes, please. Asking. Look straight, ma. If you can load, Pilocar load just go. So as you can see, the leading left orientation mark is over here. That means the lens is placed correctly. So the advantage of using a side port at the infratemporal side port at 6 o'clock is I'm able to tuck in all the 4 haptics. Spurti, can you look straight, ma? Look straight, please. Can you slightly lift your chin? Look straight. Can you look straight? Open both your eyes. Yeah, saline. Cornea saline. So once I know I've tucked in, I just want to check the position of the lens. Irrigation aspiration. So I'm comfortable using a bimanual irrigation aspiration. Spurti, we're almost done. Another 2 minutes, we're done. Okay, the lens is placed. Keep looking straight, ma. Just look straight, please. Very nice. Just keep focusing on those 3 lights. Are you okay? We're almost done. The lens is placed. Continues. Yeah. Increase the flow, please. Look straight, man. Look straight, look straight. Spurti, can you look straight, please? Look straight. Look at the green. Look at the light. Yeah. So as you can see, there are 3 central holes. The central hole is about 360 microns. This allows a good aqueous flow and also allows us to remove the OVD. I normally use a HPMC 2%. The focus okay? Good visco wash is very important. So, pilot just. Pilot. Look straight. Spurti, can you look straight, ma? Please don't move. Can you look straight, please? Spurti, can you look straight? Yeah, please don't move. We're almost done. I don't. Look straight. Looks at light, ma. Both eyes open. Jesko. Hydro. Hydro, no? కొంచెం పెద్ద సిరింజ్ లేవు హైడ్రో 5cc ఉంటుంది. I think the vault also looks good, so taking the right measurements. So normally once I finish the case, I make the patient wait for a couple of hours. I like to check the vision NCT and see how the patient is doing, and then we call the patient again the next day, and then on the 3rd day we do the other eye. Look straight. So I don't like to overfill and make it extremely hard, so it's just good enough for me to just make sure that there's no wound leak and just close the case. That's okay, it's fine. Look straight, Spurti, look straight. Yes. Spurti, surgery is done. Okay, it went on very well. Right? Wait for some time. We'll just see you and then send you off. Okay.
Nice demonstration.
Sorry? Yeah, you can close your eyes. Close your eyes.
That was an excellent surgery, Advait sir.
Thank you,
It
madam.
went on flawlessly and it's good surgical skill.
Thank you, madam. Close your
Any
eyes, ma'am.
queries,
Close
please
your eyes.
welcome. Dr. Advait sir is here to clarify.
What are the complications you encountered in your experience?
Sir, for now, I've done about around 30 ICL phakic IOLs. I've had a couple of patients with high vault, but I didn't have to expand. The patients are doing good. I've been monitoring the patients. The pressures are under control. And otherwise, I've not faced any other issue. Normally, intraoperatively with phakic IOL ICL, sometimes there's a chance of the lens flipping, which I've not encountered with the ICL phakic. I've had a couple of star ICL flipping in the anterior chamber. But because the material itself of the ICL phakic is quite thick, the chance of lens flipping in the anterior chamber is extremely rare. So that is one big advantage of the ICL phakic lens.
What about the vault problems? Any vault problems you encountered?
The vaulting again, sir, the measurement is very important. So normally we check white to white. We have a serious topography. So we check white to white with a serious topography and with the autorefractometer and also using a digital caliper under the microscope. So white to white measurement and anterior chamber depth measurements are sent to the company and they send us the lenses. So as long as your white to white is accurate, normally you don't face vault issues. But however, these lenses are extremely soft. So in case you have any such complication post-operatively, it's easy to expand the lens. And another advantage of this thing is we have a power up to -25. I've had the opportunity to implant on a patient with -27 diopters, high myopia. Of course, she's amblyopic, but she's doing very well. It's been more than 1.5 years now. With -25, she's doing very well. So that is another advantage of the biotech because they have a wider range of lenses.
Any questions from the delegates? Thank you, doctor.
Thank you, sir. Thank you so much. Thank you, everyone. I'd like to thank Dr. Praveen, sir, and biotech company, Mr. Anish and Mr. Ahmed and Sampath. They've been very helpful. And this was my first live surgery. So thank you so much.
Thank you, sir.
Thank you, madam. Thank you.
So now let's move on to the third surgery performed by Dr. Praveen. He's the chief consultant, Kakatiya Eye Hospital. He's going to give us the demo about Zeiss cataract suit. Let me brief up the patient details. A male patient named Ravindra Reddy was complaining of dimness of vision in OU with the uncorrected visual acuity in OD CF 4 meters improving to 624, and in OS it was CF 4 meters improving to 660. He was diagnosed to have an immature cortical cataract and been posted for left eye cataract surgery. The patient is being prepared for surgery. Over to Dr. Praveen, sir.
Thank you, Dr. Neeraja. Very good morning, all. And very good morning, Dr. Ravikumar Reddy, sir.
Thank you.
How are you, sir?
I'm fine.
So in one of the national conference, I saw Dr. Tityal operating on, just giving demo on Callisto eye in Ahmedabad conference. So I took at that time. It's basically markerless and an easy way for the toric lenses implantation. So pre-op and intra-op marking, we can skip it off. Microscope microscope. I'm doing from superior approach.
Is it not difficult in sunken eyes, Praveen?
Yeah, sir.
Why not in temporal?
Actually, anything can be done, sir. It's not a technical side issue. Basically, we are doing more, like, little bit more number of surgeries. So in a continuous, we always changing this way will be little bit cumbersome. That's the way we started doing like that. It's a practical issue. That's it.
We learned our superior from SICS.
Sir. Ravindra Reddy garu, em kangaru em ledhu, rendu kannu teravandi.
People is not fully dilated.
Yes, sir. So no more light ne kada, pedda light ne chudali. This as a regular practice, I use this betadine. This immediate process in so many papers I've seen that this is one of the thing which can reduce the post-op infective rate. కొంచెం గదో పైకి ఎత్తండి. ఇచ్చమ్మా కొత్తది. Paragonization. This I'm doing on the topical anesthesia. Phenacan తీసుకున్నాము. Phenacan. అమ్మా రతీష్ రెడ్డి మన just a minute, just we'll take the cell and motion. This photograph says only. So they called the patient very early in view of this live surgeries. So the dilatation has gone. I use phenocane. Ravindra Reddy. Raman. Ranjit.
So did you use any intracameral mediatic?
Yeah, phenocane I used, sir. That's what. I just am waiting for dilatation. Now it is dilated. Enough dilatation is done. Just show the monitor. So before surgery, we'll take the photograph of from this Callisto eye, and already just show the monitor, ma. Videographer, show the monitor. Yeah. So there you can see the one object, one image is from IL master, which is taken pre-op, and the second image is now taken live on the table now. So that will be now compared. And once they are fused, then the Callisto eye will guide us the axis or incision, whatever we need. So it is like cataract assisted computer assisted cataract surgery. So this is the way we take photograph. So there is little bit technical issues or what you say lag, because as we are doing the first time live surgeries here in my hospital, and my staff is also first time seeing these live surgeries. So little bit, and I regret that inconvenience to you all. And this is a show the monitor, ma. So this is a 180 axis which can be shown. So this is markerless, so no need to go for pre-op marking, whether it is stay there, the stain is there, with needle we have to take, or with the sketch, with the mark is there, nothing is left. So the lot of comfort zone will be there. Generally, I use this. Generally, I use hyaluron, sodium hyaluronate. That is, I'm comfortable with it. Rexis. Yeah. So this is 5 and 5.5 mm Rexis. So this we show the monitor once, operator. So you can see the 2 rings here. So these rings will help us for the center from the Purkinje fibers will be the centration. From there, we'll take the and it will guide us according to the size. So, and these markings, we can change the colors also. In between, you can go to live image also, operator. Sometimes screen and sometimes this one. So I am taking 5 mm. This is Emma. Incision. So it will be like whatever the size, whatever the thing we can put, whichever axis, preoply we can just feed the system, and then we can go ahead. It will properly guide us. How's the picture quality, Ravi Kumar, sir?
Yeah, fine.
Transmission is okay, sir?
Excellent.
This picture is definitely much better than what we have seen earlier.
Yeah, last time when we had the demo, a lot of issues were there, sound issues was there.
This is much better.
Light pipe, పెద్ద light pipe చూడండి రవీంద్ర రెడ్డి గారు. అలా వెరీ గుడ్. ఏం కంగారు పడకండి. chopper 2 amma. Light వైపు చూస్తున్నాను రవీంద్ర రెడ్డి గారు. Soft cataract. My favorite is top and chop technique only. Aspiration, diamond. ఇది పెద్దది ఇచ్చినాము సైడ్ పట్టించు. పన్నెండు దిగాల. ఓకే. And I am implanting Lucia, Jay's Lucia, hydrophobic tinted yellow tinted Aspirin lens. I use continuous irrigation, which I feel more comfortable, more relaxed. Maybe I will be using more BSS in that class, but more secure. Z-axis. Z-axis. No, just a minute. So this is the lens. This is preloaded. This is a beauty. Very easy, no handling of the lens. Just we need to put visco and press it. Just can you put the axis? Ranjit. Light weapon answer. Lens, the opening time also will be a little more, so you have a lot of time. So unfolding time is relatively higher than when I compare to other companies. Take it out. Amma. The next is. This will show that once. 89 millimeters. This is basically spherical, is not a toric lens, but I want to see the z-axis. Yeah, operator, show the screen. So this is the z-axis. The coloration of these lines also we can change. So see the particle, exactly the mark of the IOL will be exactly, we can fuse these three lines. Wherein relative to other things, there will be one line, these are three lines, so that in exactly we can align the lens accordingly. So this is markerless cataract, Jay's cataract suit, where IOL master and Lumera eye and Callisto eye go in hand, so and give the patient a markerless toric implantation lens. Otherwise, also helps the surgeon work so easy and helps in the rexis or incision planning, everything. Thank you all. And any questions, please.
Congrats, Praveen, nice demonstration.
Sir, thank you, sir. You are the sir. You opened my OT with your hands in 2006. So in 2014, I opened this one, and you inaugurated this OT. And thankfully, very much thanks to you, sir.
Thank you, thank you. Any doubts? What about the PC rate in your lens?
PC?
PCO.
PCO, sir. So relatively, it's almost same like any hydrophobic lens, sir. The percentage, but it is very less, but depends on the diabetic status or the patient, other inflammatory situations, but relatively very less.
So thank you, Dr. Praveen. That was a wonderful surgery with excellent precision. Thanks for enlightening the details of Zeiss cataract suit. Thank you, sir.
Ravindra Reddy garu baga in the operation lens baga kuchundi. జాగ్రత్తలు ఎలా ఉండాలో చెప్తారు వినండి పాటించండి మళ్ళీ రేపొద్దున చూపించాలి.
Thank you so much. Could the OT team please tell us how much time it will take for?
Just will tell the Dr. Sharath has to come. He has a session in the I think there only, but I think he has started. It will take little time. Better we take another session there.
Right. Yes.
Okay.
We'll wait.
Thank you.
So till then, I request Dr. Rishi Swarup sir to please take the next lecture on sustained hydration and sustained complete. The
Next case it cases చేసేద్దాం వాళ్ళకి తెప్పించాం కదా we'll do that cases. అమ్మాయి తీసేసేయండి మైక్.
This will be followed by the live surgery by Dr. Babu sir, and we'll keep you updated about it. We're actually running ahead of time.
At the outset, I'd like to thank the organizers and ALCON for giving me this opportunity and also for providing support for this meeting. I'd like to say at the outset that the slide deck was provided by ALCON, but I'll be giving my own inputs against the slides as and when they come. Okay. So I think it's a very good product which has been introduced recently by ALCON, and that is Sustained Complete. And I'm not saying it just because they have sponsored this session, but because I've been waiting for this particular molecule for a very, very long time. I think all of us who are treating dry eye patients in the clinic, we know that a large chunk, I think probably 60% of our dry eyes are evaporative dry eyes. Okay, if you do a tear film breakup time and you find a tear film breakup of less than 10, essentially you're dealing with a evaporative dry eye. And if you actually sit and check the tear film breakup time of 100 patients in your clinic, you will be surprised that at least 50% of them will have a low tear film breakup time. And I myself have an evaporative dry eye. All of us are looking at screens. All of us are in air-conditioned environments. So all of these are accentuating the problem. Dry eye is definitely a big problem in our country. Like I said, almost 50% of people have some sort of dry eye experience. And this can affect your physical health. It can affect your sleep, your psychological health, and also affect your independence that you have in your life. Which are the activities which can get affected? Reading, driving, computer use, and professional work. And people have shown in some studies that it can affect these activities from 2.6 to 4.8 times. Now, it has a compatible impact similar to many other disabling conditions, like severe angina or a fracture. So what I'm trying to say here is dry eye, it may seem like a small problem, but it can actually make the person who's suffering from it as uncomfortable as something so bad as a chest pain or a hip fracture. It is a very, very common condition, and that is probably why it goes a lot underdiagnosed. Most people have moderate to severe dry eyes, as is seen in this graph. Almost 61% have a moderate form of dry eye, which is a significant, and only a small percentage have actually got a mild dry eye, unlike what one may actually think. So it is basically an overlooked problem, an underdiagnosed, distressing problem that really needs to be addressed in a proper way. Now, what are the challenges in dry eye diagnosis? Definition of dry eye is still very debatable. There are many, many things. It's if you see the definition which is provided by the Tear Film Ocular Society, it is a long statement. So because there's so many elements in it, okay, and that can sometimes become confusing for a general ophthalmologist. There is no gold standard test, one test which can diagnose dry eye. There are some forms of dry eye which have very good Schirmers. There are some forms of dry eye which have a low Schirmers. Some dry eye will have good tear film breakup, some will have low. So there's no one test which can confirm that, yes, this is a dry eye patient or not. You have to see a multitude of tests and come to a diagnosis of dry eye based on the entire data set that you have. And many of these tests are not standardized. The way we administer the tests also not standardized. Sometimes we check Schirmers with the bright lights in the room, or one may be having a fan running at full speed, or an air-conditioned glass sitting there. All of these can affect the values. Ocular surface is sensitive to stimuli, and diagnostic tests are invasive. So that's why you can have a lot of variability. Non-invasive diagnostic tests are available. We have a lot of new diagnostic tools that are available nowadays, but they are costly, and not everybody has access to them. And in reduced ocular surface sensitivity, tests are poorly associated with the subjective symptoms. So say the people who have reduced sensations, the patient will have a lot more signs than the symptoms that they have of the dry eye. So what are the aqueous dynamics associated with dry eye? So we all know that the tear film is composed of 3 layers, which is the mucin layer, the aqueous layer, and the lipid layer. Traditionally, we are taught that there are 3 layers from bottom to above, but now we know that it's actually a matrix and everything is intermingled. So you have like a mucoaqueous layer, and on top you have a lipid layer. There are 2 distinct types of dry eye, and one which is a mixture of these 2. So when you have reduction of the aqueous component, it's an aqueous deficiency dry eye. And if you have a reduction of the stability of the tear film, which may be either from reduced lipids, or reduced mucin or increased evaporation, that is called an evaporative dry eye. But most of the time we have a combination of these two. Many patients who have aqueous deficiency dry eye will also have some element of evaporative dry eye. So if you were to sit and identify, this was a paper which showed that 50% of dry eyes are actually lipid deficient. 36 are a combination of lipid and aqueous, and only 14% are aqueous deficient. Now the problem is most of our dry eyes have, as per this study, 86% have a lipid deficiency or a mucin deficiency. But till now, we had no lubricant which was able to replenish this lipid and stabilize the tear film. So we were using surrogates which weren't working very well. You know, we have so many of these patients with dry eye who you give them any lubricant, they won't be happy. It's because you're not able to stabilize the tear film. You're just replacing the water. They're okay for a while and then they again become symptomatic once that water starts breaking up because the tear film is not stable. So various other factors also can worsen the dry eye, like smoking, contact lens use, increased use of any screen. And, you know, as our lifestyle is changing, more and more, we are becoming prone for these forms of dry eye. Even masks are known to increase dry eye because when you're wearing a mask, the air is a jet of air goes from the upper part of the mask and dries up your tear film from front. So that again increases your evaporative dry eye, and that's become another important cause of dry eye in the recent times. So we've established that dry eye is an important problem, especially evaporative dry eye. We've established the factors that are causing it, and we've also the limitations of diagnostic tests. Now, how do you go ahead and manage these dry eyes? Whenever you are treating dry eye, you want to treat the symptoms. You want to prevent the corneal damage. The tear film is there to protect the ocular surface, to improve the patient's comfort, reduce their symptoms, and to return the ocular surface and tear film to its normal state. These are your objectives. So it would be good to go in a stepwise manner, educate the patient about the condition and other supportive measures like lid hygiene, etc., dietary modification, lifestyle modification, etc. Tell them about the disease and its management. Then you give non-preserved ocular lubricants ideally, or having minimum preservatives. If you have blepharitis, you may want to use tea tree oil, scrubs, anti-inflammatory agents may be required if there's surface inflammation. And you can do other measures for tear conservation. You can use plugs, etc. Third step is use of oral secretagogues, which increase the mucin in the eye. In severe cases, you can use autologous serum and therapeutic contact lenses, which retain the tears in the eye. Finally, the step 4 is for more severe cases, you'll require some sort of a surgical approach. And sometimes you may also need to use steroids. So how should one approach the tear film strategy depending upon which component of your tears is affected? If it is predominantly a lipid deficiency, then you want the lipid to come back, which is either blocked in the meibomian gland. So you want to give warm compresses and lid massage to express that oil out and make the lid margin and the meibomian glands healthy again. You can use certain types of ointments which contain oils. But lubricants containing oils were not available until now. To replace the aqueous and mucin layer, you can use mucin secretagogues like rebapamide, etc. And then, of course, aqueous component, a variety of tear substitutes are available. To make if the epithelium is healthy, you can use, again, mucin secretagogues, and you have lubricants which kind of mimic the glycocalyx of the epithelium. Because of the presence of HP GUA. And then, of course, ocular surface inflammation, if it's there, you have to give anti-inflammatories. So I think the cornerstone of dry eye management is the lubricant. And they are essentially the first line treatment for dry eye. 2-3 things are important in a lubricant. What is the active ingredient? What is the preservative? And what is the additional supplements and additional substances that are present, which increase the value of a lubricant. I think this is where Cysteine Complete scores on all fronts. It's got a very good active ingredient, and it has got a lot of additives which stabilize various layers of the tear film. Primarily, the main thing which is important is it contains lipid which helps to increase the stability of the lipid layer and increase the lipid layer thickness. And probably one of the studies by Silverstein et al. Has shown that it provides 97% patient satisfaction, which is quite, with a single drop, which is quite commendable. So the key ingredients, in addition to polyethylene glycol and purified water, etc., is the lipid, which is mineral oil and phospholipids. It contains HP Guar, just like the other drops in the Cysteine family, which kind of binds the tears to the ocular surface, and it forms like a matrix on the ocular surface. And various other ingredients are also present, mineral oil, sorbitol, etc., which give a lot of help to the tears. The preservative is polyquad. Now, probably the preservative is the only thing which I feel is a little deficient in this. And if they can come with a milder preservative, this would be an absolutely perfect molecule. So the beautiful thing that they've done is combine the HP Guar with nano-sized lipid droplets. So what happens is these nano-sized lipid droplets get trapped in the HP Guar matrix, and they're released slowly into the surface. So they keep getting released from the matrix over a long period of time, and thereby provide a sustained stabilization of the tear film. Okay, so basically these negatively charged phospholipids get trapped inside the matrix as is shown. So it spreads across the ocular surface, these small nano-sized lipid droplets, and anywhere there is deficiencies in the lipid layer, it goes and plugs those gaps. And thus, this lubricant is able to provide a complete replacement of all three layers of the cornea, of the tear film, which is aqueous, mucin, as well as the lipid layer. And there have been some clinical trials which have supported these claims. One of the good studies was done by Silverstein et al. Basically, a single dose application, how it has affected is what this study has done. And basically, after instilling one drop, they have seen how the patient's symptoms were reduced over a period of 4 to 8 hours. Scoring was done at 0, 4, and 8 hours. And the patient was asked to scale symptoms from 0 to 10, 0 being no symptoms at all, and 10 being the worst imaginable. And you can see in all forms of dry eye, the patients up to 8 hours were finding a good benefit from using these drops, especially in the mixed component. You can see there was significant improvement. Aqueous deficient also was improved till 4 hours, but then it came back over time. So essentially what the study is showing that the effect is lasting till about 8 hours. So probably even a 3 times a day dosing may be adequate for the garden variety evaporative dry eye. Another important study was by Craig et al., which was used to develop evidence-based guidance for the treatment of dry eye disease with artificial tear supplements. And this was a 6-month multi-center double-masked randomized control trial. So patients were screened, 134 patients were screened, 99 were found eligible. And then they were divided into 2 subgroups, one that received Cysteine Complete, which is a newer drop, and another would receive the Cysteine Ultra, which was the established drop from EYECON. And what this study essentially showed that almost all the questionnaires, the Cysteine Complete and Ultra were comparable. So it was at least as good as the previous gold standard. And the tear film breakup time also was comparable between both Cysteine Ultra and Cysteine Complete. But this is where Cysteine Complete really scored over. It had much better lipid layer thickness compared to the Cysteine Ultra. And that, of course, translates into better treatment of the evaporative dry eye. So the essential difference between the previous lubricants which were there and this is the improvement in the lipid layer, which was something which was really missing in the market. And I think this is where this really fits in. I think the market is huge for these drops, and all of us and our patients will benefit from having a drop which contains lipids. It's early days. I've also just been using this drop for about a month or two, but I've used it in my own eye. I really find it much better than the other lubricants I've used in the past. And I think it has a place, especially in evaporative dry eyes. So to summarize, dry eye is a common condition that affects all aspects of the eyes of our life. And its lipid layer is the culprit in dry eye in almost 86% of dry eyes. Till now, we didn't have an option, but now we have this option of Cysteine Complete, which not just replaces the lipid layer of the tear film, but also stabilizes the tear film and replaces the aqueous component very well. So it essentially gives us a complete solution for almost all our patients of dry eye. And I think the name is quite good. Cysteine Complete would be a perfect name for this. So these are the kind of patients who would be ideal. Mid-level IT professional who's going to be seeing a lot of screens and has not benefited from your routine lubricants. A homemaker, again, loves to read, watches a lot of TV, and maybe even has some meibomian gland dysfunction, has sore, scratchy eyes. Such patients would benefit. Software, computers. So basically, anybody who's looking at screens would be ideal. Even teachers are looking at screens nowadays, online classes, etc. But it's not just the screens. It's a lot of people have got a blockage of their tear film, of their meibomian glands. Meibography is one of the tools which is able to image this very well. And such patients, I think there's a definite role for using these. Especially if you do a meibography, there are some subset of patients in which the meibomian glands are not blocked, but they are actually obliterated because of chronic meibomitis. And whatever you do, how much ever warm compress and massage you do, these patients, the oil is never going to come back naturally. So these kind of patients, I think this drop has really got a role to play, and probably they may have to use it even for life. Thank you.
Rishi, I don't have a personal experience. I'm at the back.
Yes,
Behind you.
Yes, sir.
But does this drop cause any disturbance in vision?
Not at all.
Being oil-based?
No, the concentration of HP guar is the same as Cysteine Ultra. So the only thing which can cause blurring is the HP guar. The oil doesn't cause a problem. Oil just increases the surface tension and stabilizes the tear film.
Attractive and promising option for patient of
Yeah,
computer vision.
even I was very happy when they told that. In fact, we've been after the Alcon guys. When are you bringing it to the Indian market? So finally, when they got it, I was very excited, and I'm actually finding it useful.
Live ready unnaada? Chandu live aha? Check అయ్యా ఏదో చేసినాడు అయ్యా
What is next?
Chandu respond. Check Chandu.
Thank you, sir, for your wonderful class. Actually, we have a live surgery from Dr. Sharad Babu, but it was delayed. So, ma'am, Dr. Shomashila Murthy, ma'am, will continue with her.
Chandu.
I can't see the. Yeah, I was searching for that. So I think it's a bonus presentation for me, maybe not for you, maybe not that interesting, but thanks to TOS for giving me this chance. So I just thought I'll very quickly show you some interesting techniques or how you can approach cataract surgery, especially in uveitic cataracts. So of course, we do know that it's not just about performing surgery through a small pupil, but we have to take care of the disease. That is the basic, and make sure that the inflammation is quiet and the patient doesn't have any disease activity at the point when we do surgery. And then of course we should explain to the patient what is sometimes the indication for surgery is because we're not very clear that the patient will improve visually. So sometimes the visual prognosis can be guarded. That has to be very clearly explained to the patient. So timing would be when the eye inflammation is inactive. And we do use peri-operative and pre-operative steroids, could be topical steroids or oral steroids. It depends on the severity of the case. So that's not the focus of my presentation, so I won't discuss that much. In terms of surgical technique, we have to have a plan. How will we address the problem of the constricted pupil with synechia? And in terms of the lens, we have to decide whether, supposing if it's a pediatric case, sometimes we won't put a lens, but if it's a senile cataract or if it's a cataract in middle age or young patient, what kind of lens are we selecting for this patient? And equally important is post-operative. When the patient comes back to us on follow-up, what all we need to do. Again, I'll not be focusing on that in this presentation, and maybe some intraoperative complications we can run through. So surgical technique very simply boils down to how will you manage the synechia that the patient has. So these are very hard synechia. They're not going to just break with simple viscodissection or with adrenaline or even with phenocaine. So for these kind of synechia, we need to think about either pupil expanders or even sphincterotomies or any collar button devices like Coughlin's hooks or iris hooks. Also, we use the B-hex ring and the Malusian ring, but that's a little expensive. So I either toggle between Coughlin's hooks or iris hooks and the B-hex ring based on the case that I have. So I'll just take you through a few such examples. So this is a 35-year-old patient who came who has been under my care for uveitic cataract, was lost during COVID for follow-up and then came back. By now the disease had sort of become very inactive. So I kept the patient a little bit on follow-up, and then once the eye was quiet this year, I decided to go ahead and proceed with cataract surgery. So it's a younger patient with a really mature cataract. And based on the history, I know that the patient has recurrent episodes. So I always do a peripheral anesthectomy. And my first tip that I want to sort of share with you is that it's so easy to do the peripheral anesthectomy before you start the rest of the case. So I first do that. I think you've noticed. Next is I'm using Coughlin's hooks to do a sort of a 4-quadrant stretching of the pupil. And it's a total cataract. So I will definitely use a stain to help me increase the visibility of the anterior lens capsule. Then go ahead and simply aspirate a little bit of that cortex with the help of a needle, which is what I did. And then now I'm doing the rexus. You can see that the capsule is very elastic in spite of the stain, but I didn't have to shift to a forceps. I could simply do it. And the actual phaco part of the procedure, the lens nucleus is very soft, and the eye also could be very fast. I'm not so fast. I've sped up the video. And I'm placing the lens that the patient desired, which is a in the bag. And this patient went on to have currently still under active follow-up. What I'm doing here is the remnants of a membrane. So I just snip that and I'm sort of going all around and taking out, you can see that membrane as it comes out, taking out the little membrane, which is no need for it to be in the eye. It's fibrosis. And it might cause shrinkage of the capsular bag in a way that I don't want for the patient. It might decenter the lens, so I've just taken that out. And usually at the end of the case, I do inject intracameral dexamethasone, 0.1 milligram, and that helps with the immediate post-op. That was the first case. Second, much older. Patient is 65 years old with a very hard cataract and also has chronic disease, but has been inactive for quite some time. So the difficulties here I anticipate are that it's a hard lens and there are multiple synechiae. So can we turn down some of the lights in this? Because unfortunately, I don't have great quality videos. I see some of my colleagues have, but I don't. And so if we can turn off these lights, it could be better. Yeah, thank you. Thank you so much. So what we're doing,
modify చేయాలన్నా జేబులో పెట్టారు ఇది పర్వాలేదా
a couple of rounds, trying to very gently release the synechiae, especially into my your lower, your upper side, which is my right hand lower side, is where there are more synechiae. So I'm just removing the synechiae in that area. And then is this pupil enough? It can be enough for some cataract surgeons. Some of us may want more pupil dilation, so you can choose. But I thought this pupil is enough for me to go ahead with phaco. So maybe off late, I'm tending to use iris hooks more. But at this point, I thought that I'll just go ahead and do the cataract surgery. So once you have enough pupillary, adequate pupillary dilatation, so you can go ahead and then go do the cataract surgery. Now, in this case, then I see that the cataract is so dense and so hard. So as a second thought, I think that no, this is not going to work. It's a very hard cataract and the pupil dilation, what if the pupil comes down? So now I go ahead and put the hooks. So in the first case, it was just simple hooks. Here I use Coughlin's hooks, did the rexes, and then decided to put iris hooks. Again, that's a membrane that I'm removing. Very often these. And I can. There is. Keep changing the The risk I run is that with my hook, I might tear the anterior capsular rexes, on which I've worked so hard. So it was a little bit sort of a judgment call, or maybe overconfidence, where I thought that I could handle the cataract. Counsel prevailed, and I went ahead and put the hooks, had a nice dilation of the pupil to tackle the really hard cataract that was happening in this patient. And then this is at the safe stage where I only have to do IA now. The pupil is adequately dilated. So in uveitic cataracts, if you leave something that is stretching the pupil so much for a very long time, then the post-operative inflammation is really high. And that was a reluctance for me to use the hooks in the first place. But then to do a good, safe job, you have to do what you have to do. So this patient again went to do extremely well, because the trick here is not not because of a very well done surgery, but the trick here is that the inflammation was inactive. And the iris, the peripheral iridectomy is a must have in such cases where there are a lot of synechiae. You continue to have inflammation post-op. Then what happens, what you saw as posterior synechiae will now come as and the lens. And then if you have iris. This was a 30-ish-year-old patient who had disease for a long time.
Okay.
And she was ready for cataract surgery. When it's active and the patient, it's a blinding disease, but the cataract's outcome is usually very good. And the cataract inflammation wise also, it's easy to them at the time when the disease is inactive. So that's it. So again, now it's become a little muddy boat of you now, because again, there's synechiae. I release the synechiae, go in with the Coughlin's hooks, gently stretch the pupil, because you don't want to traumatize the pupil. So like a sleeping type, let it sleep. Don't wake it up. It's something like that. So here there's no need of iris hooks or anything of that sort. Notice a little bleed on the iris. So they're very gentle. The iris can bleed because it's so fragile. Patient very elastic capsule. Didn't stain the capsule and then went ahead. The nucleus is typically soft and you can remove it by this conventional vein, which you're used to, the machine that you're used to. During the very end of the procedure. So also the cortical wash should be very thorough. Of course, one reason is that it's presumed that even the cortex can induce inflammation, but other more important reason is that wherever you have cortex, that will cause some fibrosis, and then there'll be a shift of the pupil here and there, and you can again have synechiae later on. So you'd want all the cortex to be out of the eye. So again, this patient went on to do very well in terms of the surgical result also, because her disease was very well controlled, nothing to do with surgery. This is a really tough case. This patient actually did not have very well controlled disease, but he just said that he needed surgery now, and we had waited very long, and it's a total cataract. So how long would we wait? So this is the point where to decide what is better for the patient, to walk around with no vision or to go ahead and operate. So we went ahead and operated, and it was a total cataract. So we kind of planned to also maybe might have to do SICS. So we did a limbal section, as you saw, scleral section, as you saw. Once again, nicely and wisely inserting the hooks right away and get a nice sort of a rectangle shape pupil going there, with under which anybody can do a very good phaco procedure. So there's the hardship of having a small pupil is overcome. And this patient did fairly well. Of course, had a rough journey in terms of inflammation. We had to use a lot of immunosuppression for this patient to get rid of the inflammation. And maybe the second last case is a patient who has also received Ozurdex. So Ozurdex is one drug that can really help with decreasing the post-operative cystoid macular edema for many of these patients, and it can decrease the need for
కళ్ళు తెరిస్తేనే ఆపరేషన్ అయితే రెండు కళ్ళు గట్టి మూసుకుంటే కాదు. ఇట్లా ఎత్తాలి.
ఒకసారి గట్టి మూసుకో, రెండు కళ్ళు మూసుకో, ఇబ్బంది అవుతుంది. అదే రెండు కళ్ళు తెరు,
తెరు.
రెండు కళ్ళు తెరు, ఏం కాదు నీకు, నొప్పి తక్కువ ఉంటుంది. లైట్ చూడు, ఎన్ని లైట్ ఉన్నాయి చూడమా,
లైట్ చూడు, లైట్
positive individuals already have
కృష్ణమూర్తి గారు
కింద లైట్,
రెండు కళ్ళు తెరవండి,
కింద 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 లైట్ చూడు.
ఆ మూడు లైట్ లో పెద్ద లైట్ చూడండి,
కిందకి కిందకి
అట్లా అట్లనే చూస్తా ఉండు. ఎంత మంచి చూస్తా అంత మంచిగా అయితే ఆపరేషన్.
elastic, and then go ahead and perform the rexes. So it's not very challenging, but we really want to have a good rexes over here so that we can place our lens nicely in the back.
చూపించం అది అదే 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 రాగానే అయిపోతుంది.
Really sitting at the edge of the pupil, looks like I'm
లైట్ చూడు, కళ్ళు తెరు, రెండు కళ్ళు తెరు, బాగా అట్లే చూస్తుండు, లైట్ చూడు.
these iris hooks, but I didn't, and went ahead and just the soft cataract density of cataract decides for me whether to use hooks or not, and then place the lens, and after very thorough cortical cleanup.
అక్కడ ఏమవుతుంది వాళ్ళది డిస్కషన్ మేడం దా.
It's a single piece non-aspheric lens that the patient chose.
ఇది ఆన్ అయిందా, వాళ్ళతో చెప్పొచ్చు కదా మనం రెడీ అని.
Retinal eyes won't like the way I'm giving it, but so this will help with even the post-operative cystoid macular edema.
అట్లే చూస్తా.
Pressure rise is not much. It can be very managed if at all the patient turns out to. Last case is a very interesting one.
లైట్ చూడు, కళ్ళు మొయ్యద్దు, కళ్ళు తెరిచి చూస్తుంటేనే అవుతుంది.
Cataract you can say, but he had injury. It's a traumatic cataract. Patient had injury, and there was a iris hole. What you saw.
అదే.
So this area, this is. And we can, which
బాగుంది. ఆ వెన్యూ అయితే బ్రహ్మాండంగా ఉంది. లేదు అన్ని బాగానే ఉన్నాయి, సిడి అన్ని బాగానే, కానీ ఎయిర్ కండిషన్ డీ లో కూడా రావట్లే.
Suspecting that there would be an intralenticular foreign
problem ఉంది, ఒకటి సెటరేట్ చేస్తే.
Lens capsule is already breached because there's an injury. Just simply separated that one single synechia, and because most of the capsule is intact except at the site of that injury, so it sort of did rexes from two areas, two locations. So use the one on either side and get the inferior half. So sort of a tug because of. And then now very carefully. We expect there's an intralenticular foreign body. One more way of doing this.
70
SICS, so you're much more certain of getting that foreign body out. But here we're using the Phaco Pro, and all the time with low parameters.
అక్కడ ఎవరు తెలిసిందో లేదు, దాని అడ్వాంటేజ్ అనుకుంది. నేషనల్ 70 పెట్టు.
So I don't know if you noticed.
Proceed.
I don't know if you noticed, but that is the foreign body. So we stopped our Phaco for a while, got the foreign body out, kept it on the cornea just to show you that it was intralenticular foreign body. See, we got it. There could be more pieces, so we searched really thoroughly. for the time.
ఎవరు కాంటాక్ట్ అయ్యావనన్నా
And after doing IA, we gently sort of shook the eye, you can say. If there's any foreign body somewhere, we reassure that we should be getting it out.
ఎవరికి
Should be getting it out. And then after I skipped touching all over, we retracted the pupil, the iris, and we looked at everywhere in the pharmacies. So this patient did very
ఓహో
well.
అది లైవ్ కదా అందుకే నువ్వు మాట్లాడుతున్నా అర్థం కాదు
అయిపోయినాక ఇప్పుడు ఆ టైం ఎందుకని 2 కేసులు కొట్టేసినాయి వాళ్ళు డిసప్పాయింట్ అయిపోవడం
ఓకే ఓకే నైస్
I feel is for each and every patient, I prefer to do Ozurdex. Along with the
ఒకసారి ఫోన్ చేసి చెప్పరు అది రెడీగా ఉందని అది తర్వాత మాట్లాడతారుగా
long term, at least 3 months.
లైవ్ రెడీ పెట్టమన్నా లైవ్ స్టార్ట్ సౌండ్ హలో
హలో సోమశీల వి ఆర్ రెడీ
One is of course the expense, that is number one, I guess.
రైట్
And
చూస్తా
that limits us.
రెండు కళ్ళు తీరు ఇందాకట్లాగా
There have
Light
been
చూడు
reports
కింద.
of, viral retinitis after Ozurdex
Light
injection. So, and we're not 100% sure that the patient will get CME. So if I have a very well-managed case, say anterior uveitis and all, I may not.
లైట్ చూడు కింద
I reserve it for those very bad cases
చూస్తేనే బాగా అవుతుంది లైట్ లైట్ చూడు
where the patient has a very stormy course. You're using medication, patient comes back with recurrence or very active disease. So those patients, and when I know what the retina looks like already, so we don't want to miss a case of viral retinitis because you're suppressing the retina locally. So the possibility of a viral disease goes up. So that's the only problem.
Have you seen any
Yeah.
retinitis?
Yes, yeah. It's been
After
reported
Ozurdex?
also, yeah.
Important.
ఇప్పుడు మూడైనాయా
Well, I haven't, but the retina colleagues would
No,
have.
I haven't seen.
Okay.
Report. Theoretical, but what is
ఫస్ట్ రూపకు
the cost?
అయిపోయిందా ఓకే ఓకే అద్వైతం
Yeah, I agree with
కింద
you.
చూడమ్మా
That if I could use it more often, I definitely would.
సోమశీల వి ఆర్ రెడీ
Thank you so much, ma'am. Special thanks to you for
అది పోవట్లేదు అక్కడికి
such a short notice. Thanks a lot, ma'am.
లైట్ చూడు లైట్
We
లైట్
have our next live
కింద లైట్
ready.
యా వి ఆర్ రెడీ హియర్ ఆర్ యు ఏబుల్ టు హియర్ us
Yes.
Yeah, I am Dr. Sharath here, and this is one patient by name Krishnamurthy. And as you see, you can see a posterior subcapsular cataract in this patient. And the IOL specifications, what I am going to use it is the Optiflex IOL. It's a trifocal IOL. It has got some advantages as it is a trifocal for both 80 centimeters and near and for distance, for 40, 80 and for distance. It's a plus 3.5 addition IOL. It's a diffractive IOL. And I've been using this IOL from the past 1 year. And about the range of vision, as you see, this is what I was talking about. And then this is the patient after coming. We make sure that every patient who is walking into our clinic, that they have been advised multifocal if they are a right candidate for a multifocal. So how do we decide whether the patient is a multifocal candidate? This is the case sheet which of this patient. He walked in, and then this is the visual acuity, counting fingers 3 meters, not improving. He's got the posterior subcapsular cataract in the right eye, and the left eye very minimal sclerosis. Next scan. And this is the OCT. We do OCT for all the patients whom we think that they are fit for multifocal. And before this, we do the scan. And it's IOL Master 700. We do that because it takes care of both the anterior and posterior curvature of the cornea and gives the true keratometry readings. And in this patient, he's the ideal candidate because it's 0.22 diopters of astigmatism in this patient. This is in the right eye. Even left eye also, you can see it's almost the same. So now we are operating a Optiflex IOL, and this is the patient Krishnamurthy, and I am Dr. Sharath from Warangal. Now what we are using is we are using the Alcon Centurion phaco machine, and the parameters is I love the surgery doing a stop and chop technique. Stop and chop is making a trench, making it 2 halves, and then eat away the cataract, and then put the lens. So this is what usually I do, and I've done all type of surgeries, and then I landed up with the Stop and Chop. Light చూస్తా ఉన్నాను కృష్ణమూర్తి గారు కళ్ళు మూయొద్దు. Bleeding. So I'm using this IOL. This IOL goes through 2 millimeter incision, but here I'm using a 2.4 mm because 2.2 is what we are supposed to use. But then I found that 2.4 mm blade is very good because one is all these 2.4 mm incisions. When you use a phaco machine, a Centurion, it has got two types of sleeves. One is the blue one, light Chodan Krishnamurthy garu. It has got two types. One is the blue one, other one is the red. The red one, what we are, they're supposed to have the incision of 2.2, but 2.4 is more convenient. And this is in my experience. I have seen that. So in this patient, because he's not that cooperative, I used a intracameral phenocaine, that is the topcomide, phenylephrine, and lignocaine. So always side port, I use a 24 gauge needle. Why? Because the entry is sufficient for my 26 needle to go inside, because I'm using a 24, and also that is a cheaper one than the side port. So I fill the antechamber with the visco. I use only methyl cellulose for all my patients, unless there is a hypermature cataract where I use sodium iodide. And here I am doing a capsulorhexis. The capsulorhexis is done nicely. Light చూడండి కృష్ణమూర్తి గారు కింద అట్లా. So my incision is bleeding. Most of the corneal surgeons doesn't like it because I do a posterior limbal incision for all my patients.
Switch off those floodlights.
I know. But astigmatism, patient control in my hands is good only with this incision. I tried all incisions, but doesn't matter for the patient. Post-operatively, I will be quite. So I've done a hydrodissection. Now I'm doing a trenching with the phaco machine. In my theater, phaco machine on the right side, here it's on the left side. Little bit difficult for me, but anyway. Thanks to Alcon for giving this phaco machine, new tip and all.
So, Dr. Shadbabu, can you hear me? Can I disturb
Yes,
you?
yes, Dr. Somshila.
So, when you have a soft cataract like this, so what is your plan of attack?
I didn't get it.
So it's quite a soft cataract. So you doesn't look
Ah.
What is your surgical approach?
Usually for any cataract, I do the same. The reason is that depends what I do the next part. The central core I separate it. Second, I do a trenching for every cataract, but if it is a very soft cataract, I do it differently. I do a hydrodissection immediately after this so that the two halves just come into the AC and then I finish it off. Now the second part I'm doing, put the 40, power is 40 or 30 will be fine. Because here what I wanted is, I wanted the pieces to come forward, but they're not coming in probably.
Can the audio visual make this screen bigger, the surgery screen? Yeah. I think
Light చూడండి కృష్ణమూర్తి గారు. ఇటు లైట్ ఇటు పక్క. అట్లా. So I'm repeating my hydrodissection because that's the lens is not following. Probably As so much I was telling, it's a soft cataract. There is some problem. The AC deepened too much. Light చూడండి. ఇంకోటి ఫిల్ చేసి లైట్ చూడండి కృష్ణమూర్తి గారు. సెకండ్ లైట్ చూడండి, లైట్ చూడండి. ఐఎమ్ ట్రయింగ్ టు hydrodissect and then see whether the lens is freed from the capsule. It's taking a while. Put more visco. My power 30 పెట్టు. So with the less torsional power, I am trying to take out the cataract. Let us see. The AC is deepened. That's what I'm a bit worried about. Second elevator. It's more sticky. Second 30 లో పెట్టండి పవర్, నాట్ మోర్ దాన్ దట్. అయితే 20 పెట్టండి.
So, sir, you have transited to this machine for some years now, right? Essentially, Dr. Sharadan.
Yeah, what do you suggest me to do?
No suggestions. We know you'll get it. No, I was
No,
just
no.
trying. How do you find this machine different from? I think maybe you were using Infinity, or for the surgeons here. So, what are the tips to when you start off with this machine?
Infinity, I will. Not able to focus very clearly. IP పెట్టొద్దు, తీసేయండి.
So just when Dr. Shadba was operating, just wanted to chip in that in soft cataracts, what happens sometimes is that much of he's done very adequate hydrodissection, but there is some way in which it just gets sort of tethered into the bag, and you really have to wait for one end to prolapse into the phacoprobe. And once that happens, then everything starts coming out. It is as if there's some inertia for the nucleus or the epinucleus to come out.
Yeah, the iris is cut.
Doing that maneuver.
Dr. Babu, did you manage to crack it or?
Yeah, I've done that, but it's not coming in.
What I found useful in these kind of softish cataracts is to use a little bit of viscoelastic to kind of prolapse the.
Light chudandi. Yeah, I'll do that now. Light chudu. Kinda. Atlaga. See the crack. More important thing is this patient is my counselor's dad. Light children, light. 20 lo unda second lo 20 lo better. I think the crack is incomplete and that's why I'm having this problem. Vacuum ఎంత ఉంది? రావట్లేదు ఇది. కిందే చూడండి కృష్ణమూర్తి గారు కళ్ళు.
Some Finnegan.
లైట్ చూడండి కింద. వద్దు అదే ఉంచు చూద్దాం. లైట్ చూడండి కృష్ణమూర్తి గారు.
I think there's a very important lesson here that Dr. Sharad Babu is.
లైట్ చూడండి కిందకి. లైట్.
You have these patients who are unconscious.
అయ్యేమా?
The pupil comes down and things are not as per plan, but sir is very calm and going about it in a very, very relaxed way.
యూపీ 75 పెట్టండి.
Yes, surgeons.
So I use a bimanual only for patients with complications, but here I'm using coaxial IA. లైట్ చూడండి, కింద లైట్ ఇట్లా కిందకి చూడండి, లైట్ వైపు. Now I'm showing the IOL. Here, this is from the Medicell. This has got two type of cartridges and then the unfolders. This is one of the best unfolders and cartridges I have seen in the market. Any type of lens goes very easily inside through a sub 2 mm incision. So this is the IOL. This has got a blue filter, but not exactly, it doesn't look more yellow like a panoptics.
Sir, is this the Optiflex Trio lens?
Yeah, this is the Optiflex Bio.
So it's a bifocal lens.
No, it's a trifocal lens, biotech from the biotech.
Biotech. So it's Optiflex Trio.
It's a trio lens. Kindiki చూడండి, లైట్ కళ్ళు తెరవండి బాగా, కింద లైట్ చూడండి, లైట్ వైపు లైట్ కళ్ళు మీద రెండు కళ్ళు తెరవండి, కళ్ళు తెరవండి బాగా. కళ్ళు తెరవండి బాగా, లైట్ చూడండి, లైట్. యా, లైట్ చూడండి. లైట్ వైపే చూడండి. So I clear the visco from the anterior surface and then wash posteriorly little and then light చూడండి. Do a whisk aspiration. Light చూడండి, లైట్. ఇదంతా ఇదైతే ఉంది. లైట్ చూడండి, లైట్. ఇది ఇటు పక్కదే. ఎస్, లైట్ కింద చూడండి, కింద. ఎస్, అయ్యేమో ఇదంతా ఇదైపోతుంది, ఫాగ్ వస్తుంది. ఫాగ్ వస్తుంది ఇది. హ్యూమిడిటీ ఎట్లుంది? లైట్ చూడు. My eyepieces are getting fogged. Light, student. I'm leaving behind a little bit of peripheral cortex. I would have not, but place is different for me. I'm not. Light, చూస్తాను. ROM. హ్యూమిడిటీ ఎంత ఉంది తెలీదు. లైట్ చూడండి. My eyepieces are getting fogged because of the humidity. Light చూస్తాను. Temperature కాదు, హ్యూమిడిటీ. లైట్ చూస్తాను. లైట్ చూస్తాను. నాకు ఐపీస్ బ్లాక్ అవుతాను. ROM. From the last 1.5 years, I am using the RO, intracameral RO for all the patients. Kalithiral valve. Intracameral Moxie, yeah, from the RO company. Yeah, that's it. Any questions on this IOL or?
Well done, Dr. Sarath. Patient.
Yeah, I tried. I almost sweat here because
Beautifully
to me and
You have taught us the virtue of patience.
yeah.
I request Swaroop and Somashila to give some more tips how to handle a very soft cataract.
Yeah, please.
Very soft and very hard cataract is difficult. Grade 2 is easy, grade 3 is easy. Hard cataract is difficult and very soft also difficult. They will give some tips for the young surgeons.
So as far as in my case, soft cataract main problem is that it cheese wires, so you don't get a good hold. So if you're you used to do the traditional stop and chop kind of a maneuver, that's pretty okay for soft, but you have to make a narrow trench. You shouldn't make a wide trench, narrow and deep trench, and then try to crack it with 2 Sinskey hooks. Go deep and just make a little crack, and if you're able to get a crack, it's well and good. What I try and do in these cases, in most of my cases, in fact, it's really soft cataract. I just hydroprolapse the core nucleus or whatever there is, the core lens matter out. I aspirate or emulsify that. And after that, the epinuclear shell, I just viscoprolapse it. I think with that quickly, the whole thing comes out of the bag, and then you just put your phacoprobe. Most of the time, just with aspiration, it comes in, or you have to use very minimal phaco, maybe in epinucleus mode, and you're done in no time. So most of the time that works quite well. The key is to go just under the capsule, hugging the anterior capsule till the equator. And if you inject at the right place, everything gets prolapsed from one side. And then with the same cannula, you have to go behind the prolapsed epinucleus and displace the whole thing anterior. That's what I usually do, and that works for me in soft cataracts.
Very good tips, Rishi, exactly as you said. Just one for me, what I make sure is that after hydroprolapsing the nucleus, or as much as I can, sometimes even, don't do a detailed hydrodissection, delamination. I avoid that in soft cataracts. So try to hydroprolapse it and then put viscoelastic, go with the foot switch off. So sometimes when you go with the foot switch on, the fluid will again push it back into the bag. So go off and then first put it into the center of that nuclear material. And it's like the lollipop kind of analogy I can think of. So hang on to the nuclear material and then put the foot switch down. So everything just gets gobbled up. You don't do trenching, no finesse. There's no finesse over there. So it's not by stop and chop. It's more like hook or crook kind of a technique is how you get it out. And the epinucleus is pretty much, as you said, sometimes we as surgeons, once we are doing a step, we don't like to interrupt, come out, and then put some more viscoelastic. So, but here we have to do that. So that's the only way to get it out. Interrupt the phaco and not want to do everything in one go.
So 0 or grade 1 hydrodelineation, as you all small incision surgeons are well versed, prolapse into AC, within no time you can aspirate. Afterwards, instead of hydro, viscodelineation, viscodissection. the visco will go behind and take the epinucleus into the AC. The things will become so easy.
I think this case was complicated by the patient being a little uncooperative and the pupil coming down. Both of them, I think, pose a
Yeah,
little-
otherwise the little resection would have done that.
Another very useful thing in these cases. Even harder nuclear pieces, sometimes you can take away with the eye tip if you're using a stuffing technique, which is very nicely demonstrated by us.
So the cooperation of the patient generally I do is whether they are cooperative for indirect ophthalmoscopy or not. If they are not cooperative for indirect, I prefer to give the block. Congratulations for all the surgeons who have guts to do the live demonstration. I heartily give the congrats and compliments for this young surgeon
Yeah, thank you very much.
for demonstrating. Sarath, anything?
Any questions from the audience?
Praveen?
We have time, so it'll be good to discuss.
Praveen?
Sir.
There is a question at the back. Please come to the mic, sir. There's some mics there. We can't hear you, sir.
No audible, sir? Is it audible, sir?
The center, sir.
Nice surgical setup, Praveen.
Thank you so much, sir. Thank you all.
Suitable for multifocal IOLs are extended range of vision.
Who are the patients who are suitable for multifocal and ERV lenses?
Yeah.
Sir, Dr. Bansal, maybe you would like to take that. Which are the patients unsuitable for EDOF and multifocal lens?
I will not use these lenses in patients. Number one, have got high astigmatism. And then I prefer not to use this patient who are night drivers, who drive at night on a regular basis. And of course, patient who have got very high expectations. Then again, patient who have got retinal pathologies, those patients again I'll avoid.
First question is highly demanding patient and he is having a work of 12 hours, 14 hours. We discourage because of computerization and all that distances may not be suitable. But casual household ladies, politicians who doesn't want to wear the glasses, I prefer to put them. Whereas the professionals, they want the color vision perfection. Perfection means there is no perfect multifocal lens. Whereas EDOF lens will tolerate all the things. You need not consider so much. But one request is ocular surface, whether there is a dry eye or not. Second is the topography or the pentacam readings, whether if it is irregular, don't give the premium lenses.
I think beautiful points, sir. And one more thing I think is it's also good to look at the macula in detail. Sometimes many of these patients have a small epiretinal membrane, some vitromacular action, etc. And all of these can really affect the outcome of your premium lenses. So it would be good to do an OCT ideally for all cases. And especially if you can't see the macula so clearly, or if you feel the cataract is not corresponding, just do an OCT to see if the retina is all right. And of course, irregular astigmatism. I had a patient who wanted a multifocal, and luckily our optical biometer also has a central topographer. I saw there was significant amount of irregular astigmatism. He had a very small atrophic pterygium at the limbus, which didn't even go 0.5 millimeters into the cornea. But funnily, that was causing a lot of effect on the central cornea. So I told him, no, we won't do a multifocal. I suggested a monofocal. And on table, I took off the pterygium and his irregularity completely went away. So sometimes even a small pterygium may look innocuous, but it can affect the central corneal topography quite a bit. And it can affect the outcome.
I'll add up something else, Rishi. Can you hear me?
Do you advise?
Yeah. Can you hear me? I'm Dr. Sharath here. One more thing we need to add up is
advice.
We need to
advise.
We need to ask every patient about a history of refractive corneal surgery. One patient I operated, 71 years old patient. I thought the LASIK was available only in 96 in here. So I didn't ask him about the history of LASIK. So I just went and operated because he was wearing -4.5 both eyes from long. So after surgery, after putting a panoptics lens, he was not happy. So I went back and then did everything. All of them are good. Then I went for a pentacam and then I saw irregular cornea. Then I asked him any history of LASIK surgery. He got LASIK surgery at the age of 46 years on one eye, and that is the one which I operated. And it recurred immediately, and then he was wearing -4.5 from then onwards. But he didn't feel any difficulty because the other eye is good. So after that incident, I started asking every patient about the history of refractive corneal surgery.
Good one, sir.
So Dr. Babu, do you want to comment on the surgery that you did? Because we were.
Yeah. In this patient, patient is not cooperative. I used intracameral. Usually I don't use the intracameral phenocaine. And in this patient I used, but then the cataract, usually it comes out because the pupil is not that in between. Accidentally I caught the iris, the pupil, and then it became small. But otherwise, with the hydrodissection, after making two pieces, usually they come out very easily out, and then I just finished off for phacoing. But here I found out that difficulty here. So I had to repeatedly do that and then get it out. And of course, the center is different, and then the humidity I could not see from the eyepieces because too many people are here inside. The humidity is changed, but now it's fine again after that.
The flow rate also will increase the holding
Do you
capacity.
base it on the axis? Dr. Babu?
Yes.
The incision, the clear corneal incision, is that the default incision for you? Superior temporal, or
I do posterior limbal for all my cases. I do a little bit of nick, and I usually for all my patients I open up the conjunctiva a little bit. So 2.4 incision around 2.6 or 3 mm, the conjunctiva is open in that area. And after the surgery, it closes nicely the wound, and then my astigmatism control is really good in with this incision. So I settled for this.
so you don't place it on axis, on steep axis?
No. My surgical induced astigmatism is 0. So I put any incision anywhere, it is the same. So accordingly, I calculate my toric lenses and then go ahead and then implant the IOLs accordingly.
Okay, you prefer superior or temporal? You operated today.
Always my incision is 110 to 115 degrees in any eye, either left or right is the same.
Okay. So anything, Praveen?
Thank you all, sir. Thank you all for really the great opportunity, and welcome to Warangal, all of you, and thank you. And let's have a great time in these 2-3 days, sir. Thank you.
Thank you all.
Good of you.
Thank you, sir.
I come to know that there is a half an hour time for lunch. To utilize this time, I request our Chairman Scientific Committee, Dr. Santosh, to speak on common eyelid surgeries. Your time around 30 minutes, sir.
We can stop the live feed, I guess.
Yeah. You can stop that.
Get ready for delightful extravaganza. Dr. Santosh has some beautiful videos, and he's one of the best teachers I've ever heard. So please enjoy. Mike.
I think I have an enviable task of coming in between, lunch and all of you. But then these surgeries are not going to be as clean as what you saw. These are oculoplasty surgeries. So obviously you'll see some blood that may reduce your appetite.
Please reduce the floodlights.
Yeah. If you can reduce the light, that will be good. So I have a huge bunch of surgeries, but I'm not going to show you even 10% of it, but try to take you through some of these. Let's start with congenital ptosis. Giving practical examples, this lady has just about 2 mm of ptosis. So in such patients, what we do is measure LPS action, and if levator action is 10 mm or more, then she can definitely be a candidate for mullerectomy. So then you do what is called a phenylephrine test. If phenylephrine test is positive, Then you go for an internal conjunctival approach mullarectomy, which is calculated obviously based on the amount of doses and the patient's phenylephrine test positivity. And if suppose phenylephrine test is negative, then you have to go back to the age-old Fassler-Savart procedure, which is called tarsoconjunctivo-mullarectomy. In mullarectomy, you do conjunctiva and Muller's excision, whereas in Fassler-Savart procedure, you bring in excision of the tarsus as well. So this video clip shows Fassler-Savart procedure. It is done under local anesthesia. A small frontal block is what is given. This is the patient who we're going to operate, about 2 millimeter ptosis, 10 millimeter levator action. So after giving frontal block, you invert the lid and mark the center, which corresponds to pupillary axis, and pass 3 porosilk sutures through the everted margin of the tarsus. That is how we begin. 3 sutures. 1 in the center, 1 medial, and 1 lateral. This will help you stabilize the folded lid. Then you ask the patient to look down and pass a suture from the superior fornix, coming out just short of the lid margin. The purpose of this I'll show you a little later. And when you pass the suture on the lateral side, you should be careful not to pass through the palpebral lobe of the lacrimal gland, otherwise there will be brisk bleeding. So we have a set of 6 sutures now, so sometimes confusing, all these sutures, but these will help you a lot during further surgical procedure. So what we next do is use a lid spatula or a lid guard to support the eyelid and mark the amount of excision. The amount of excision is simply twice the amount of ptosis. Suppose a patient has 2 millimeter ptosis, then you have to excise 4 millimeter. If a patient has 1.5 millimeter ptosis, then you have to excise 3 millimeter of the tarsus, which means that you will be excising equal amount of palpebral conjunctiva as well, since the lid is folded. Then you mark that area of excision using a bipolar forceps that will get you very good hemostasis. Then, having supported the lid with a lid spatula, you excise that amount of tarsus and tarsal conjunctiva, and on the reverse side palpebral conjunctiva as well. So I'm using radiofrequency electrode. You can use carbon dioxide laser as well. These are very good agents to get hemostasis. Otherwise, you can simply use Barpakan knife and scissors. That's not bad at all. Gets you little bleeding, but that's perfectly okay. Results don't change with the instrumentation. Then you lift the lid off the spatula and then excise that portion. So it's a kind of folded lid, tarsus, tarsal conjunctiva on one side and palpebral conjunctiva on the other side. Of course, sandwich between these two is the Muller's muscle. Levator does not get disturbed in this process. So having excised it, now we have to suture it. And for suturing, we mark the proposed site of the ends of the lid crease. Use a plain 6-0 catgut suture, which has been moistened well so that it is not abrasive. If you fear that it may abrade the cornea, you can always put a bandage contact lens temporarily. The knot is outside. Then you take the suture in. Now the second set of sutures actually helps you get the posterior aspect of the cut conjunctiva very much into the surgical field without having to keep digging into the fornix to get that bit of conjunctiva to suture. These are buried sutures, 6-0 catgut, which gets absorbed in about 7 to 10 days. Or you can use a fast gut, which gets absorbed in about 4 to 5 days. Then you bring the other end of the suture out through the skin for you to tie. So if you have to remove, sometimes catgut can be a little variable in terms of its absorption. You can simply cut the knot from the skin side and pull the suture out if you really have to remove it. That's about is the surgery. And results are very encouraging because this is a surgery which actually is well standardized. Whatever you measure, you get. Unlike levator resection, which has variable outcome, Fassler-Savart and mullerectomy have one of the best outcomes in ptosis surgery because exactly what you measure, you get. And also lid crease becomes normalized. You can see in the right eye, she had a higher lid crease to begin with. That kind of got normalized following surgery with the left eye. So it's a very good surgery to do. In patients who have little more ptosis, say 3.5, 4